So we're here today on a very sunny day in March 2025 to talk to Dr. Jane Lochrie, and we're in her home in Shrewsbury here. Let's talk about just what got you interested in a career in medicine.
Well, I actually started out as a nurse's aide at the old Boston City Hospital, and I worked in pediatrics at the time. It was interesting times where we had one code cart for 7 floors. If we needed the code cart, I'd have to run downstairs and say, code on whatever floor I was working on at the time. I was a student nurse at the time, and there were times when I was the only nurse on the whole floor doing IVs. So that really got me interested, and then I went to nursing school. I graduated from Boston College, and then I started working at Mass General. After that, I worked at the Mass Hospital for Handicapped Children, and I met a pediatrician there who I told him I wanted to go to medical school, and he said, no, you really want to be a nurse practitioner. So I went to Northeastern and did nurse practitioner school.
When is this?
Nurse practitioner was 1977.
Okay, and when did you enter nursing school?
1968.
Oh, okay, great.
So I took the long way around, but I'm really not sorry I did it. I think nursing it gives you a really different perspective. You know what it's like for a patient not to be able to eat for 24 hours. I have to stay in bed. So I think it was an interesting way to enter medical school. But
so this is interesting. You functioned in the role as a nurse, and you wanted to be a doctor. How did you visualize your relationship with patients being different in one role versus the other?
I didn't really see it as difference. I think it's, always the caring of the patient and listening to what the patient has to say, working with the families. It's all similar. We're all trying to reach the same goal, taking care of the patient, getting the patient better if possible.
Then what drove you to say, well, geez, I want to take many more years to complete my education by becoming a doctor? What drew you in that direction?
Well, when I worked at Mass Hospital School, and I was working as the pediatric nurse practitioner, and I was pretty independent, and that was very early for nurse practitioners to be independent. And I was being supervised by orthopedic residents, and there was a patient who was really very, very sick, and I had no idea what was wrong with the patient. And I talked to one of the orthopedic surgeons and said, could you come and see the patient? And he said, children get sick very quickly, but they get better very quickly. And I was like, no, there's something wrong with this patient. And I called the ambulance and took the child to Children's Hospital, and it turned out the patient had meningococcemia, which was complicated by his muscular dystrophy. So, but he did make it, and I came back to the hospital school, and it was then I said, no, I really want to be a doctor.
You want to be in a position where you can sort of act on your assessments a little more effectively.
Right, exactly.
Interesting. So where'd you go to med school?
UMass, proud graduate, 1983.
1983.
Yes.
And you entered when?
1979 is when I started medical school, and I graduated in 1983.
Okay, that's more. Okay, fine. I heard. Okay, good. And what was medical school like in those days? How big was your class?
My class was 100. We all knew each other very well. It was a lot of camaraderie. There were 10 women in my class, and we all felt like, oh, we finally made it. 10% of the class is women.
And what did you feel about your education at that point? Was it particularly stressful or difficult?
So I think the first 2 years, where a lot of the medical students had taken a lot more science courses than I had, and having gone through nursing school, it was very different. But once I got out onto the wards, it was easy. I knew how to talk to patients.
Sure.
knew what a doctor's order was. I knew that you couldn't write it in the progress notes.
Mm-hmm. So you were very familiar with the clinical delivery of care and basically needed a little catch-up regarding the basic sciences.
Exactly.
Yeah. Good. And did you feel there were only 10 women in the class? Did you feel that you were viewed as an equal, or were there, were you treated differently?
I don't think so. I think, everybody got along. Everybody was friendly.
Mm-hmm.
I can't say that the faculty treated me any differently.
Mm-hmm. Okay. And then at some point you decided to go into internal medicine?
Yes.
And what drew you in that direction?
So I really liked pediatrics, and I really liked OB, and I liked everything, but I think internal medicine, the patients were able to say what their problems were a lot easier than the pediatric patients. I loved the differential diagnosis. I loved examining patients. I loved looking at every single hair follicle to try to make the diagnosis.
Uh-huh.
And I mean, things were very different back then. It was a lot. We had more time with the patients than people have now.
Uh-huh. And did you, one of the things about internal medicine is there's a lot of chronic illness, and there are a lot of issues in which the illnesses are the result of lifestyle habits that the patients can't quite change. How did you rate that? Is that something that you found frustrating, or is it something that you were okay with?
No, I felt like it was a challenge to get somebody to say stop smoking. And you just keep working with the patients, and every once in a while you get a win, which absolutely feels wonderful. I remember one time I had a medical student in my office, and one of the patients that I was working with was a smoker, and when he said to the medical student, went right in front of me, she's going to start asking me about smoking now. She really badgers me about this. But he did actually stop smoking. So.
Oh, excellent. And where did you do your residency?
At St. Vincent's Hospital.
How'd that go?
Great. There was probably 5 or 6 of the residents with me had graduated from UMass, was in my class, so it was like old home week. In fact, some of the people I'm still working with, even at St. Anne's.
And as far as a typical work week, how did that go?
So it was every third night in the ICU, every fourth night on the wards. I loved being an intern. I knew everybody's potassium in the whole hospital. It was a lot of camaraderie. You had overnight to write all your histories and physicals. It wasn't today. Looking at the residents, and they have to be out of the hospital at a certain time, and they're really stressed to get things finished on time. Where we had 36 hours to work on our histories and physicals, and think about differential diagnoses, and discuss with the attendings who were usually around early in the morning. Medicine was very different then. As far as the work week, how many hours would you figure would be a typical work week for you? Probably about 100. And did you find you're dealing with the sleep-wake cycle or exhaustion or anything? Was that challenging? So I'm one of these people who don't really need to sleep a lot. So I didn't really. I know some of my colleagues did. Of course, there were times when, it was every third night in the ICU when you were there, when you were tired. But I never really felt like that it was too much, or I've always felt like I was learning, and which was my goal. And so things have changed. There have been more in the way of work hour limitations and consecutive hours and
as well as, total hours in a week and things like that. What is your perspective on those changes that have been implemented since you did your residency?
I think there's a lot of plus and minuses. Like I said, we had a lot more time to think about what we were doing, to think about the differential diagnosis, to look things up. But on the flip side, errors get made when people are tired.
Mm-hmm.
And I think there were good reasons for the changes.
Mm-hmm.
But if I had my druthers, I would stay there for 36 hours.
Mm-hmm. And do you feel, so at some point you decided to go into general internal medicine and not subspecialize. What was your thinking on that?
So back then, primary care medicine, and they didn't even call it, they called it general internal medicine at the time, was the specialty that people went into. A very few members of my class subspecialized.
Mm-hmm.
And I wanted to take care of the patient, from soup to nuts. I didn't want to just take care of the heart or just take care of the lungs. I wanted to take care of the whole patient.
Mm-hmm. And when you were caring for patients during your residency in the hospital, was most of the care to them delivered by their primary care doctor or by a subspecialist?
Most the patients were admitted to the general internal medicine, and it was taken care of by their primary care doctor.
Mm-hmm.
And I think that gave them a great transition. I mean, when patients are sick in the hospital, they want the doctor that knows them the best. If they have to make decisions about end of life,
mm-hmm.
they want the person who knows them the best to help them make those decisions.
Mm.
So I think that was one of the reasons that I also wanted to go into internal medicine,
mm-hmm.
to help people make those decisions.
Do you recall back in those days if a primary care doctor who admitted their patient to the hospital brought in a subspecialist to consult on that patient, did the subspecialist write orders, or did the subspecialist make recommendations to the primary care?
They did both. They were able to write orders.
Okay.
And oftentimes they did. And
Okay.
I think it really just depended on this subspecialist, what their preferences were.
Okay.
A lot of them would call you and say, I saw your patient and this is what I found. This is what I think we should do.
Right.
I'm here. Do you want me to write the orders?
Right. Okay. And now, in general, what was your encounter in those days, the early, mid-'80s, with managed care systems or insurance systems? As a resident, did you get any exposure to that?
I did, because St. Vincent's was really affiliated with the Fallon Community Health Plan. And we did get a lot of exposure to that. And one of the reasons what I decided to work at Fallon after I finished my residency was because of the patient had the ability to see a subspecialist for $2, and it wasn't like it was a big deal to see a subspecialist. And oftentimes, I could consult with a subspecialist just over the telephone or in person. I could run upstairs and show Dick Bishop an EKG, and he would go over it with me, or Morris Bearer would, be looking at chest X-rays with me. We were all in the same building. So that was one of the main reasons that I chose to work at Fallon.
So that's another issue, because Fallon was basically a salaried system, as opposed to private practice, which was fee-for-service, and there was a direct relationship between your income and your volume. That was less so with Fallon. And did you have thoughts about that when you were deciding how to practice? Was there one place where you were more comfortable?
Well, that's an interesting question, because the first time that I went for my annual review, and we would once a year, they would go through and they would say, this is how much money you spent here, this is how much you spent there. I was the first female internist at Fallon Clinic, and when I went, Joe Pogbilski, who was the president at the time, said, "How come you spend so much money in radiology? All your other, values look this, on par with everybody else's. And I was like, I have all female patients. They all need mammograms. And he was like, oh, I never thought of that.
Mm-hmm.
So I didn't see as many patients as other people because I did all my own pap smears. And most of the other physicians just sent their patients to OBGYN.
Right.
So I was prepared the next year. I brought a copy of all my pap smears to say, this is why I have to take more time, seeing my patients.
You have fewer GYN referrals.
Right.
Yeah, interesting. And so you joined the Fallon Clinic, and what happened to your work hours compared to your residency? How was that transition?
They did. It was a different kind of work balance because when you were on call, you were very, very busy. But during the week, we would make rounds in the morning on our own patients, and usually I had 4 patients in the hospital. So I'd get to work like around 6:30, depending on how many patients I had, maybe 7, and I would be there till probably about 7 o'clock at night. But there was the nights, we were on call for our own patients, but we didn't get that many phone calls. I mean, occasionally we did, but we were on call for the weekend from, you get up on Friday morning and it wasn't until Monday. And they were, we had 6 or 7 people in our call group. And we covered, all the outpatient, all the inpatients, all the nursing homes. Everybody had their own nursing home that they were responsible for. They had something called HMO call. So if you belonged to the Fallon Community Health Plan and you didn't have a primary care doctor, all the phone calls would go to you. And that was usually once during our weekend on call. We also saw, if we could, the emergency room had what they called the courtesy room. So if we saw a patient that we thought might need to be seen, we could see them there.
Nice. And from the point of view of, a typical day, so what sorts of, how many patients would you see in a day, once your practice was kind of in a mature, steady state?
Probably about 20, and depending on how many, I would see all my comprehensive medical exams for 45 minutes, so it really would depend on how many comprehensive exams that I had. And we'd go through everything with the patients, all their medications, what they needed, for follow-ups.
And a follow-up visit or some sort of repeat visit, how long would you spend on that?
About 15 minutes.
And this is in the 1980s or so?
Yes.
Okay. And in those days, what were the typical conditions that you would treat?
So a lot of what we see now, COPD, diabetes, hypertension, high cholesterol.
And what sorts of, among those diseases, if you look at how you treated them then and how they're being treated now, what sorts of changes have occurred? What sorts of progress have been made?
So I think all the new medications, the statins have really changed the way we treat cholesterol. All the new insulins and the new hypoglycemic medications have really also changed, and they work a lot better than what we had, just regular NPH and regular insulin.
And so what sorts of improvements, when you talk about managing a diabetic, it's better today. Could you sort of give me a sense as to how it's better? Is it easier for the patient? Are the results better?
The results are better. The follow-up, the hemoglobin A1C, really, a patient could fast for 24 hours and get their blood sugar down, and I would say, oh, your blood sugar is great. But the hemoglobin A1C, which will check the blood sugar for 3 months, really gives you a better idea of their glucose control. The new medications work much better. They're much more expensive. When I worked for Fallon, most of our patients could get their medications, they would be covered. Whatever I ordered would be covered for $2.
And did you stay with Fallon, or at some point did you make a decision to change?
I stayed with Fallon while I was seeing patients. Now it's the Reliant Medical Group. My patients always came from that group.
Yeah.
In 1990, when St. V's was changing over and Dr. Levinson came back, he was the program director and the chief of medicine when I was a resident. When he came back, he asked me to help with the medical students. So I gave up some of my some of my hours. I didn't give any of my patients up, but I gave up some of my hours to meet with the medical students. Then as time went by and Dr. Levinson stepped down and I became the associate program director, I did give up some of my patients. And then when I became and I was doing both the medical students and the associate program at the time. Then when I became program director, I was just seeing patients 1 day a week.
Okay, so you really dialed that down. And so how did Fallon deal with that? Is
They were really very good. They were very supportive of it. I mean, the residents really do a lot of the work for the physicians. And so my salary was paid by the Fallon Clinic, but St. V's reimbursed them for my hours that I worked at as a program director.
And how did your practice change between the mid-'80s and, recently?
So when I first was in practice, I think that, we saw our own patients in the hospital. We took care of our patients in the nursing homes. And that, once the hospitalist movement came, Fallon was like, you can't see your patients in the hospital. I shouldn't say you can't see them. I could see them, but I didn't get paid for it. And I always, I was in the hospital, so if my patient was in the hospital, I always went to see them. But so that really changed the way we practiced. Lifestyle-wise, I think it was, very good for the physicians. But I think for the patients and for my own personal preference, it was not. I like taking care of patients in the hospital. You saw all the subspecialists. It gave you some intellectual gratification.
And how else did things change? So did the coverage group stay about the same, or?
They did, and a lot of people who go to work for that group have really stayed with them. Some of the people that I did my residency with are still working there.
Yeah.
And they had a really very good group of very strong internists, which was really good for the subspecialists also, because the more primary care doctors they had, the more patients for the subspecialist. And when I first went there, a lot of the subspecialists took care of their if they was a cardiologist, they would do the primary care for that patient. But that really changed over the years as they got more and more primary care doctors.
And has the specialty of general internal medicine evolved to the point where you would be, or others in the specialty, let's say, would be more inclined to refer patients who have diabetes or to an endocrinologist or hypertension to a cardiologist? Is there more use of subspecialists now than there was when you went into the specialty?
I think there is, and that is because I think of time constraints. Nobody is going into primary care anymore. It is really difficult to find a primary care doctor right now. So that you don't have as much time to spend going over a lot of things with the patients. So I think there is. Also, I think the patients demand it. So medicine has changed, and general internal medicine is now either you're a hospitalist or you're an outpatient specialist.
And do you have any theories regarding why fewer people are going into primary care? Because you said that when you went into internal medicine, everybody was going into general internal medicine.
Right, 50% of my class went into internal medicine. So, and I think a lot of it is lifestyle. it's it's nights, it's weekends. Where if you were working for a computer company, probably making the same amount of money, you'd be working 9 to 5. It's a harder specialty, and it's probably one of the lowest paying subspecialties. And if you did a general internal medicine residency, you could be a hospitalist and work every other week.
Mm-hmm.
Although the hospitals were very, very hard while they're in the hospital, but it's kind of you don't get called.
More predictable.
Yeah, exactly. It's a lifestyle thing that
Mm-hmm.
I think, and it does pay more than the outpatient does.
So you're not married.
No.
And as you look around at your colleagues, more of them are women.
Mm-hmm.
And would you say that of the women who are in medicine, a lot of them may be married to other doctors?
I was married to another doctor, to a psychiatrist.
Mm-hmm.
You think I would know better. But yes, there is a lot of physicians married to other physicians.
So that almost puts a time pressure, it dials up the meter on time pressure to a little bit, would you say?
Oh, absolutely, especially if you have a family and children, and they need to pick up from the daycare or from school.
Yeah. And would you say, just looking back, early 80s, 70s, that on the one hand, more of the doctors were men, but of the doctors who were married, a smaller percentage were other professionals or physicians?
So yes, and a lot of the physicians were married to women who stayed home.
Mm-hmm.
And just took care of the
Mm-hmm.
children and the general shopping and picking up the laundry and all that kind of stuff.
Mm-hmm. Yeah. So we hear a lot today about burnout in
Mm-hmm.
medicine, and what you've described to me is a situation in which there are more accommodations today for lifestyle. Mm-hmm. The hours are more predictable, maybe a little less. Mm-hmm. And did you hear much about burnout or the like early in your career?
Never. That word never came out, and I think until into the 2000s.
Yeah.
Mm.
So any theories on that? What's your perspective?
So I think a lot of people back then were able to make their own hours, and now almost everybody either works for the hospital or for a big clinic. They have few people have solo practice, and they had control over everything. And now it's like you have the insurance company telling you what medications you can order, what kind of tests that you can do. And I think a lot of that is frustrating. The electronic medical record is another big problem with, before I would just write, when I was checking out a patient, I'd say, order a CBC beforehand. Now you have to put all that information yourself into the computer.
Mm-hmm. And a lot of the computerized medical records, the doctors who were using them didn't participate in making the choice about what to use or how to use it.
Exactly. And the electronic medical record is really about how you're getting paid.
Billing.
It's billing, and it's not to make your life easier. It has made it much more difficult for the physicians.
So, as I listened to you, the first thing you brought up when we talked about what may be behind burnout was autonomy or control of one's profession and their practice. And when we started the conversation and I asked you about why you chose to be a doctor rather than continuing to be a nurse, what I heard then was that you liked more control over the practice of medicine. And you wanted to have a level of autonomy to be able to put your thoughts and assessments into action.
Exactly.
So so in some ways, I think that may be one of the things that defines physicians as being a little more in the autonomy camp than nurses who may enter the profession with an expectation of in some ways taking orders, working with a group, working in an organization with their structure and rules.
Mm-hmm.
Does that make sense?
It does. Nursing is a very difficult profession, and I think the physician comes in and says, "I'm going to order this test. You can't eat until tomorrow," and then it's the nurse who has to listen to that, listen to the family. When is this test going to be? Nobody calls me and says, "What time is this test going to be?" My husband can't eat, or my mother can't eat, and so I really do admire the nurses, and I still keep my license to this day. I still have my nursing license because I did work hard for it. And, and I still feel like my heart is, partly with nursing. When I, see a patient in the hospital, I always turn their pillow over to make them more comfortable. It was just part of me.
Yeah. Interesting. So, how do you view retirement? What's the thinking there?
So, I was really very concerned that I was going to be really bored during my retirement, but I do have a lot of hobbies, and as you know, I've been working at the free clinic 2 nights a week, and as medical director, there's all the labs and pharmacy calls comes to me. So that keeps me busy, and it keeps me, I think, fulfilled. Mm-hmm. I love working at the free clinic. I've been working at St. Anne's for 29 years.
So how did you make the decision to retire? At what point did you say now's the time?
So there were a lot of different reasons. There were a lot of changes at St. Vincent. And the chief of medicine was retiring at the time, and we had a very good working relationship. And it was just, things were changing, and I just felt like, I was 67 at the time, and I was like, this is the time.
Mm-hmm, that was right. And let's get back to your volunteer work. So you volunteered at St. Anne's Clinic. You want to tell us a little bit about St. Anne's Clinic?
Sure. St. Anne's was started by Jerry Claymont, who was a vascular surgeon in 1996. And I had been to Guatemala with him before he opened the clinic, and he did a lot of overseas surgeries, and had asked me to go with him to one of his clinics. And so we had a good relationship. And once he opened the clinic, he said, I opened a free clinic. Do you want to come and help me out? And I said, yeah, I really, I love that. I love taking care of patients who really need to be taken care of. And 22% of Worcester live below the poverty level. And these patients, there's a huge need for the free clinics, especially now with our current political climate. So I just started working there once a week, and then when Jerry was stepping down, he asked me if I wanted to be medical director, and I said maybe in 2 years, and he found somebody to be the medical director for 2 years, and then once I retired, and actually it was before I retired, I took over as medical director.
Mm-hmm. Nice. And the population now, 22% of Worcester lives below the poverty level. If we listen to the state and use their numbers, 97% of the state is insured with health insurance. Did you see patients in the free clinic who may have had health insurance?
We do, especially now, but a lot of patients, when they say they have insurance, they have Mass Health Limited, which only sees them for emergencies. And a lot of patients who have insurance have like $5,000 deductibles. I mean, that's like not having insurance. Mm-hmm. In fact, I saw a patient a couple of weeks ago who owned a gas station, and he did not have insurance at the time. And he said every time he walked out to a car that he had chest pain, and he had been seen, had stents placed, and he was like, you know what, I'm gonna have Medicare in 3 months. I was like, you can't wait 3 months.
Right.
And he goes, I have a $5,000 deductible. I cannot afford that. So I think there are, and like I said, there's nobody taking primary care patients now. Most of the practices are full. And I saw a OBGYN physician one day in the free clinic. She said, my primary care doctor left and I can't find a doctor. I mean, this is one of our colleagues.
Wow. So you would see some things that are kind of routine, such as school physicals, but you would also see people. You would be like the walk-in emergency room essentially for this region.
Right. I mean, we've seen appendicitis, ectopic pregnancies, acute MIs, DKA. I mean, patients just are just waiting for us to open. And St. Anne's, because it's been around so long, a lot of patients know about it, and a lot of the patients know about it by word of mouth from other people in their neighborhood or their friends.
And this St. Anne's opens one night a week,
right?
And on that one night a week, roughly how many patients would come through there?
So it's variable during the school year. Early school physicals, we'll see 80 patients. Right now, we're seeing about 60 patients. We have a lot more physicians than some of the other free clinics, so we're able to do that. Plus, we offer a lot more services. Labs and X-rays, which some of the clinics don't offer. Immunizations, which most of them don't offer.
And how many doctors are there seeing 80 patients?
That is also variable, but probably like 5.
And how many hours is it open?
Well, it's supposed to be open 6 to 8, and I usually get there earlier. And we're there. Last night we were there till after 9:30. So, and it depends on how many patients are really sick. I mean, a work physical might not take that long to do, but somebody who came in like last night, who came in with an ulcer on her leg and had surgery in India. She was visiting, and she had been on IV antibiotics. I mean, we had no idea what had been going on with her, because obviously we had no medical records. So we're going to see her again on Thursday night just to see how she's doing.
And are there any means of the various free clinics in Worcester communicating with each other if the same patient goes to more than one place?
So I'm at the St. Peter's Clinic also. So I mean that's easy. If somebody's going to send somebody that come up and say, I'm really worried about this patient's blood pressure. But for the other clinics, occasionally, we'll get a call, but usually we don't.
And do you see the free clinics evolving in any way? Are there changes between the 1990s and now?
I mean, I think they're getting much busier, and the type of patient that we're seeing is different. Like in the 1990s, it was a lot of work physicals, a lot of school physicals, a lot of not so much seeing hypertension, diabetes, because those patients all had primary care doctors. Now, a lot of patients don't have primary care doctors, and so we're seeing a lot more primary care. But unfortunately, we can't really refer them because we're not in any kind of network to a subspecialist, and the subspecialists don't really want to see patients who don't have insurance.
So that problem persists. Okay, well, we've covered a lot here. Any other thoughts regarding your career in medicine?
So I think things have changed. I think women are much more visible now. When I was being interviewed for Fallon Clinic, I was being interviewed by an elderly pediatrician who asked me what I would do if my beeper went off when I was in the beauty salon. And I thought he was kidding at first, but he wasn't. And I just looked at him and said, same thing you do if you were in the barber shop. And I said, I think you go to the barber shop more often than I go to the beauty shop by judging from the length of our stay. Our hair, it's just, it's really that type of thinking is no longer in vogue.
And with regard to the capability of medicine between the time you started and now, a lot more success?
I think medicine has changed a lot, and between the AIDS epidemic and the COVID pandemic, I think medicine has changed a lot. Some for good, some for not so good. Like primary care not being available anymore. I think that the medications have changed. We're able to do a lot more for the patients. Still, I still really believe that the history and physical is the baseline of medicine. I feel really sad seeing, the physical exam in particular. People just read the electronic medical records and really, they're typing into their computer, not even looking at the patient. And even as a patient myself, I feel that way. So, we have better ways to make diagnoses with newer equipment and better medications now. But still, like you were saying, lifestyle is still very important and still needs to be addressed. And I think it's probably not being addressed as much as.
Do you have any thoughts into how that could be improved?
So, it has to be a cultural thing. It has to be through, people, going into in medical school. It has to change. And I think UMass does a great job doing that with their standardized patients, and standardized patients will, give them feedback that, you're looking at your computer, you're not looking at me. Eye contact is so important. And, as when I was a nurse, then they talked about the therapeutic touch, that, talking to the patient and letting them know, that you're there. And I always think of one of my patients who, she called me at 6 o'clock in the morning, said I was having chest pain since 2 o'clock. And I said, oh, you should have called me earlier. When we sent her to the hospital, she had an emergency cabbage, had a stormy course, had a balloon pump put in her groin. It perforated her groin. She lost a lot of blood, went back to the OR. She was intubated, and I went to see her in the SICU and for a couple of days. And when she was extubated, she was like, oh, Dr. Lochrie, I felt so bad for you. I was like, felt bad for me? Why? And she goes, I could tell you had a terrible cold and you looked sick. And after all she had been through, that's what she was thinking. That
what a relationship. That's a wonderful relationship to have with a patient.
It really is. And that's, I think, really the whole basis of how, patients will, respond to you, how if you, tell them this is what I think you should do. And oftentimes they'd say, what would you do, Dr. Lochrie? What if this was your mother, what would you recommend? And that always makes me feel, so good that, somebody would feel that way.
Great.
So,
thank you.
all right.
This was a very good conversation. I appreciate you taking the time.